This is what I'd like to do with you today. I want to start by talking about competing paradigms of mental illness. We'll talk a bit about the biological or genetic paradigm, and then a trauma or dissociation, or if you will, life experience paradigm. And then we'll talk a bit about schizophrenia and psychosis from a historical perspective, looking at how they were originally conceived and how they're thought about today. And then moving more deeply into the clinical focus, we'll be talking about delusions, particularly from a trauma and attachment perspective. And then I'll talk about hallucinations from a dissociation perspective. And hopefully there'll be enough time to talk about issues of differential diagnosis at the end and the importance of the so-called first-rank symptoms, which were developed by a German psychiatrist, Kurt Schneider, and were argued to be essentially pathonomic for the diagnosis of schizophrenia for many years. In conclusion, we've proposed that delusions may serve multiple psychological purposes. First of all, they bind overwhelming affect. So people develop delusions in order to reduce their affective arousal. They may also serve the purpose of keeping traumatic memories out of awareness. Many people who are traumatized are motivated not to remember. They don't want to know what happened. Developing a delusion is a good way of ensuring that we're not making the connection to the earlier experiences. Instead, we're developing a delusion. They've also argued that dissociation can take a number of different forms, that there's psychological dissociation, but there's also somatic or physical dissociation, and that the symptoms can be positive. And as in psychiatry, when we talk about positive, we're talking about intrusions, something that is there that shouldn't be there, or negative symptoms. That's the removal of something that should be there. So examples of this would be positive psychological dissociative symptom would be flashbacks. That would be a classic one, that you are having intrusive memories or experiences from an earlier trauma. They're coming into your mind. They shouldn't be there. They're positive and they're psychological. And hallucinations can also be thought of in the same way. A negative would be amnesia. You don't have memory for something that you should have memory for, which occurs in many traumatic experiences. But there's also body sensations. So uncontrolled movement or pain in parts of the body that may be symbolic. I told you the story early on of that individual who was having this choking sensation or difficulty swallowing. That could be thought of as a somatic or a physical positive dissociative symptom. One can also have negative somatic symptoms, analgesia, anesthesia, blindness with hysteria in the 19th century. These negative physical symptoms were common, that people couldn't see for no medical or physical reason. So just remember that the dissociation can involve an intrusion or a withdrawal, and it can be physical or it can be psychological.